And my guess is as people finish up their morning, we'll have a few other people hopping on.
All right, you want me to go ahead and get started?
Yeah, sounds good. Well, welcome everybody to our fourth and final webinar for the Ohio Chapter American Academy of Pediatrics polyarticular JIA webinar series. We're really excited to have you join us because this is a little bit different. Our first three webinars really were much more didactic driven. This is really going to be much more of a sort of a panel discussion. We've got a great panel of experts, a really multidisciplinary that I'm going to introduce in a few minutes. Laura, you want to go ahead and advance the next slide? So for those of you that don't know me, I'm Chris Peltier. I'm a general pediatrician in Cincinnati, and I'm also the president-elect of the Ohio chapter of the AAP, and I'm the primary care leader for this project. And my counterpart and partner in crime, Jennifer Huggins, is a pediatric rheumatologist at Cincinnati Children's, and really just have to thank her so much because could not have done this without her expertise. It's been fun to work with her again. Next slide. I'm going to just briefly introduce our panelists. You're going to get to hear from all of them as we sort of progress. But you'll see we have sort of a wide breadth of knowledge and experience. So Dr. Ann Lynch-Jordan is a pediatric psychologist in the Division of Behavioral Medicine and Clinical Psychology at Cincinnati Children's, and is sort of an expert on sort of social, emotional, behavioral aspects of pain and helping children and their families deal with that. Dr. Tracy Ting, who you're going to hear from in just a little bit, is the medical director of the Division of Pediatric Rheumatology at Cincinnati Children's. Dr. Chris Bowling is pediatrician and founding partner at Pediatric Associates in Northern Kentucky. And Chris is going to give us sort of a primary care lens as we discuss these issues. And Chris is a national leader on using motivational interviewing techniques to encourage change. Next slide, Lori. Shannon Darnell, who, if you were on some of our previous webinars, have met before. She is a physical therapist in the Division of Occupational and Physical Therapy at Cincinnati Children's, and also has some children that have some similar issues. So she also has a parent perspective. I'm really pleased to welcome Chelsea Gilchrist, who is a young adult with polyarticular JIA and rheumatoid arthritis that really, Chelsea, since you were 18 months, I believe you told me, correct? You were diagnosed at a very young age. And so we're going to get to hear sort of her experience, both as a child, but also as she's gone in to become an adult. And for Dr. Bowling and I, Chelsea is a huge Cincinnati Bearcat fan. And also, we didn't put this on here, but she's also a big Taylor Swift fan. So, and I actually met Chelsea on Bearcat social media. So I love it when my worlds can overlap. So Chelsea, thanks for joining us.
Absolutely.
Thanks. And Barb Precht, who's the executive director of the Ohio River Valley Market of the Arthritis Foundation, who's going to give us talk about some resources that the Arthritis Foundation has that can sort of help our kids and families dealing with chronic pain. Next slide. We have no relevant financial relationships with any ineligible companies. Next slide. All right, so as we try to do throughout these webinars, we're gonna begin with a case. Lori, you can go ahead and hit enter again. So you're seeing a 15-year-old with well-controlled polyarticular juvenile idiopathic arthritis in your office. She comes in today because she's been complaining of all over body pain that has worsened in the past 4 months. The pain developed following an appendectomy that she had for acute appendicitis. She's been late or has missed 2 to 3 days of school per week because of her pain and just difficulty getting out of bed. She no longer is able to play soccer or is engaged in any aerobic activities. And formerly an AB student, she is now failing 2 classes. They are spending more time in their bedroom and less time with their friends. Your review of systems is positive for nearly every symptom. Next. And on physical exam, she's tentative palpation everywhere you touch. Their joints are hypermobile, and there are no signs of active arthritis. Next slide. So just in the chat box real quick, if you want to just sort of tell me what you're thinking, is the most likely diagnosis a flare of her pJIA, B, generalized hypermobility, C, chronic pain syndrome, or D, do we chalk this all up as a complication of her having her appendix out? And we'll just see. So we've got to vote for chronic pain. Chronic pain. Lori, you want to show us the right answer? And I agree, chronic pain syndrome. Next slide, Lori. So again, we're not going to focus a lot on didactics, but we wanted to set the stage and talking about just a slight review of some of the things we've covered and really talking about chronic pain. So it's my pleasure to turn it over to Dr. Ting, who's going to lead us through these brief number of slides. Tracy?
Yeah, thank you, Chris. So Dr. Huggins has previously shown a table, and actually maybe we could go to the next slide that we thought again, just to, as you're in clinical practice and you have 10, 15 minutes with your patients, quickly trying to put the pieces of the puzzle together, how can you start to categorize your differential? I think all of you are likely very excellent at this, but we wanted to give some distinguishing features between inflammatory, mechanical, and chronic pain. Certainly for somebody who has active, say, juvenile idiopathic arthritis, they're more likely to describe morning stiffness and symptoms that are worse in the morning. There are specific joint symptoms, but not necessarily pain, more stiffness, aching. Pain isn't necessarily worse with activity. In fact, it should be better. And patients will have swelling, and it's more of a constant swelling. And then no other features typically in terms of pain sensitivities, and certain subtypes of juvenile arthritis may develop or present with fever and rash. Then when we are referring to more mechanical joint symptoms, say generalized or localized hypermobility syndrome or overuse conditions, patients will tend not to have morning stiffness or morning symptoms, but in reverse, more pain with activities. It might actually waken them from sleep, but generally speaking, there's no associated other features of fatigue or pain sensitivities, but patients may describe some intermittent swelling. And again, likewise, no fever or rash. And then when you're thinking about chronic pain conditions, I'm certain that many of you have had these patients, but again, you can see there's more positive features. So morning stiffness, but it's not just in the morning. Actually, it's reported to be patients feel stiff all day long. Joint pain for sure is present, but it's not just the joint. So if you really get to ask about where the pain is, it's often located in muscles as well as bones and kind of widespread or kind of all over pain. Pain is worsened with activity. Again, no specific time of day that pain may be worsened because again, it tends to be throughout the day. I think a key feature or two key features will be fatigue, a description of fatigue, and if you really get a chance to ask, pretty poor sleep hygiene. They may report some intermittent swelling, but typically not constant. And certainly these pain sensitivity features of allodynia, hyperalgesia, and frequently patients will describe some mood disturbances. Next slide. So we wanted to also validate that the nomenclature is quite complicated when we're talking about chronic pain syndromes. I look at this Venn diagram, it's old, but if you look at it on the right, you kind of see that it's just a jumble of different conditions and they overlap in certain areas and then not in other areas. But the names on the left are some of the more common ones that are utilized for chronic pain. And I think sometimes appropriately so overlapping in condition and sometimes maybe less so. Unfortunately, the stigmata of juvenile fibromyalgia a decade or so ago has made us sort of think about using other conditions or other names such as chronic widespread pain or amplified pain. So again, it is complicated, but these are some of the terms that your patients and families are reading about and hearing about. Next slide. So what is pain? I mean, we know pain has both a very subjective, but yet also an objective component to it. And pain by definition is this sort of unpleasant sensory, but yet also emotional experience that's associated with some tissue damage, whether it's actual damage or potential damage. And there are different types of pain. So we're most familiar with the kind of nociceptive pain where, you put your hand on a hot stove and you've got to remove it before you burn yourself. There's the neuropathic pain, which is more like the phantom limb pain, where something about the nervous system, whether the central peripheral nervous system isn't working correctly. Inflammatory pain is really a type of nociceptive pain, but this is our patient with juvenile arthritis who has active active arthritis in a joint. Again, there's tissue damage related to that arthritis, and that's causing your brain to process pain. Then there's certainly types of mixed components where there's different features of these different types of pains, and then there's the undetermined, and sometimes we may think of chronic pain also as somewhat of a mixed picture, but also the non-inflammatory, sort of non-neuropathic pain. And this figure on the right is very basic, but I like the fact that it just sort of describes, on the left, the rectangle is really your peripheral sort of your stimulus. Is it noxious stimulus, like touching your hand on a hot stove? That pain signal will go through your nociceptive receptors, go through the dorsal horn of your spinal cord, telling your brain, hey, this is bad. And then your brain, therefore, as it's perceiving pain, depending on other features, which is this sort of triangle here on the top right, other factors can affect how one sort of manages pain or what they decide to do with pain. But typically, most of us would then remove the hand from the hot stove. And we'll talk about, use this graphic here in the next 2 slides to talk about chronic pain. Next slide. So just briefly, you guys have the article that was attached for this session, but chronic musculoskeletal pain has been defined as just ongoing pain in multiple areas. So again, joints, bone, muscle, soft tissue that's present for at least 3 months or longer. Hyperalgesia, for those of you who are not familiar with that term, again, it's where something that's normally painful, let's say getting a shot for arthritis, is typically somewhat painful because it's a shot, but it's like 10 times worse or 100 times worse for that patient. And then there's allodynia, again, a pain sensitivity process where something that's not so tender suddenly becomes tender. And this is where the historical kind of tender point exam for fibromyalgia has its basis, where again, typically a thumb is pressure, but not pain. But for patients who are experiencing chronic pain, that signal is altered and all they feel is pain. Next slide. So what's really behind chronic pain? We still have a lot to learn. There are the main sort of overarching idea is that there's altered pain processing, that somewhere between putting your hand on a hot stove or somebody putting your thumb on your back, that message that gets to the brain is misconstrued and it becomes extreme pain. We do know from evidence and literature that it's multifactorial. So lots of factors are at play. There's genetic factors, hormonal factors, obviously psychosocial, environmental factors as well, and a whole host of things here. Ultimately, we still have a lot more to learn about the pathophysiology of chronic pain. Next slide. I think one of the most common theories, there have been several proposed for chronic pain. The most common one is central sensitization theory. It's been proposed for patients who have, again, in adults with rheumatoid arthritis or lupus, or certainly with fibromyalgia or even Ehlers-Danlos syndrome. That this theory is the idea that, again, there's a mismatch in terms of the signal or the stimulus and how our body interprets pain. And I think this is where I added a few graphics. So Lori, if you don't mind pushing a few buttons, I think, yes. So the typical, this is the normal sensation pathway becomes blunted or blocked, so to speak. And then next, enter button, please. Thank you. And one more. Essentially, all these typical standard non-painful stimuli become painful, and it just ramps up under the sort of temporal summation of pain, where essentially some minor trigger will lead to increasing amounts of pain with time. And some of you may have heard of the gate theory, and this is where, again, the gate essentially is wide open. Next slide. So that's just a brief summary of pain in a nutshell. I mean, we know pain is very real, so we want to make sure to describe some of the understandings that we have to date.
All right, so now you are seeing a 15-year-old with well-controlled pJIA in your office. Again, still sort of same scenario here, right? So nothing's changed. When you're thinking about what important feature of chronic pain is really not discussed in this case scenario. You can just enter it in the chat. Yeah, sleep. Lori? Sleep. Yeah, next slide. So we're going to really just kind of now sort of open it up to our panel, and really just talk about a general approach to our patient case. So I think first, if it would be okay, Chelsea, I think I'm just going to start with you because I think, and you could probably talk about ways in which your experience has been similar to our case presentation, and maybe ways it's been different, and just talk a little bit about sort of your journey and your experience. And again, you and I have never met, but we've interacted a lot on social media, and I feel like I know you, and you are very open about sort of sharing your journey and your struggles. So maybe you just kind of start, and then I'm going to open it up to sort of our other clinicians and therapists, and sort of see what we can come to ideas to help with these kids we see in our office. Chelsea?
Sure. Yeah. I mean, I obviously do like struggle with, pain and everything. But when I was 18 months old, I was diagnosed with juvenile idiopathic arthritis. It was rheumatoid arthritis back then. But yeah, I struggle with that. And then when I was 15 years old, I was diagnosed with fibromyalgia, because I went to the doctor and I was in a lot of pain, and they couldn't really pinpoint exactly where it was coming from. So they diagnosed me with fibromyalgia. And then a couple years after that, I was then diagnosed with Ehlers-Danlos syndrome, and kind of going through that, and adding that to my journey as well. But yeah, it's kind of interesting just to go on like with, everything and being in pain and everything like that.
Let me ask you this question in full disclosure. So both my wife and my daughter have fibromyalgia, so I'm very in tune. And can you talk a little bit about sort of, I think, what we might call sort of hidden diagnoses, right? Like, so somebody that doesn't know you, right? Obviously, you're not for the most part, right? If you look, nobody would know that you suffer from chronic pain, right? Or fibromyalgia. So, what's if you sort of experience that, where people just kind of don't understand and expect you to sort of, maybe not understanding why you might not be able to go to work that day, or why when you were in school, you weren't able to go to school.
Oh, absolutely. I mean, it still happens like to this day, where it's just something that, I just have to be really honest with people, because you can't obviously tell that anything is wrong with me just by looking at me. So it's one of those things where I just have to be extra cognizant of telling people that if I'm having a really bad pain day, that what I'm experiencing and everything. But it is difficult to to share necessarily about like exactly what I'm going through, every single day, and everything like that. But yeah, it's definitely really difficult.
Thanks. And I'm going to kind of open it up to some of our other panelists. Feel free to jump in. If something that they're talking about has worked for you or didn't work for you, I'd love to hear your sort of experience with that. Dr. Bowling, since we are often, you and I are sort of, we have patients like Chelsea and other patients that sort of come to us. You want to just kind of give before we eventually hopefully get our patients to see some of our experts that are under, in the panel with us, what's been sort of your experience, and what are your struggles in sort of seeing kids when we're in a busy pandemic, we're seeing 30 kids a day, and you have maybe 15, 20 minutes sort of with this 15-year-old patient, and what are some of your struggles?
Well, I think, one of the biggest struggles I've always had with really with chronic disease in general is as a provider, you always feel like, at least I always feel like I need to have a game plan on how I'm going to approach it. If I go into an interaction and I just don't know where to go, I feel like, am I helping this patient? I don't even know what to ask. And Tracy and Jennifer have been hugely helpful in helping me get a kind of an approach together. When we were talking about doing this, I just think of some words of wisdom that I've gotten from both of them over the years. Really about when we talk about chronic pain and pain associated with other illnesses, number one, being very, really keeping the judgment out of the discussion, like, oh, well, this shouldn't be painful, or that shouldn't be painful. Like that just has to go out of the discussion from the beginning. And then I also think having a very organized approach, really stressing those things that we can control that really make a difference: exercise, sleep, nutrition, mental health, all those things that, and they're not like, minimizing pain whatsoever. They're really very important, critical pieces that we sometimes forget about. I think we get so focused on other activities. And it's really important, we think about pharmacology, we think about surgical procedures, we think about all these other things that we have to do. And we really give short shrift to some of those things that are most effective when it comes to chronic pain, really paying attention to those things like sleep, like nutrition, like exercise, like, like I say, like mental health considerations that make those things more manageable. So and again, not using them to say like, oh, you need to do these, really letting people know that these are an important piece of medical therapeutics. It's really addressing those issues.
Thanks. And I put a message in the chat. We really want this to be as interactive as possible. So please feel free, to type in questions, and I'm happy to moderate those to our panel. We're going to kind of keep talking, but send us, cases that you've had, questions you've had. What would you do in this situation? Because, we really want this to be helpful for you and helping the patients that you see. Dr. Lynch Jordan, you and I have gotten to know each other, and we've shared many patients, in full disclosure, you've seen my daughter. Can you sort of, obviously with the pandemic, we've seen a spike in mental health, but, this was a problem pre-pandemic and it's only gotten worse. Would you maybe just kind of talk about some of the issues that you see in your kids that are referred to you with chronic pain syndromes, and, how you sort of help them with that and what your goals are, talking about, I think one of the biggest things, talking about maybe that process of first trying to figure out, people get fixated on a diagnosis, then they want all of their pain to be gone, versus how do you live with that and be functional?
Absolutely.
Before Anne gets going, can I just also,
Of
I
course.
just want to also remind that, Barb Precht is a parent of a child with arthritis who suffered a lot as well. So at some point, because I know you guys as pediatricians, you treat the patient and also a lot with the parents. So at some point we'll hear from her perspective as well. Sorry about that.
No, thanks, Jennifer.
No, absolutely. And I probably should just clarify. So I am a clinical psychologist, but I am essentially a health psychologist, and I specialize in working with kids and teenagers and young adults with chronic pain. So I often refer to myself as a health coach to my patients, in part because there is, pretty understandably, pain is difficult to understand, especially as a kid or a teenager. Being sent to a psychologist often feels invalidating, especially if it's not explained in a way that helps people understand coping with chronic health problems, or if the person has just had a bad experience with a counselor or therapist in the past and then kind of assumes it's the same thing. So I teach a lot of coping skills related to managing chronic pain. And I like to use the toolbox analogy because, I kind of joke, I'm like, gaming is a great distraction tool, but you can't do it in the middle of math class, even for our more advanced adolescents, I'm like, smoking marijuana could be a great coping tool, but guess what? It's illegal. So it really emphasized the idea that the broader array of coping tools they have, there are tools for every situation. I do a style of treatment called cognitive behavioral therapy. So it really is addressing thoughts, behaviors, beliefs that could be accidentally not helping the management of pain. And I always tell my patients I have the luxury of not having to know exactly what their diagnosis is, which I know is different for my medical colleagues, but that I still have tools that can help people function as well as possible and cope as well as possible, so that they can ideally get to Chelsea's level where, you know, she is balancing her health needs with living daily life. But when someone is younger, they may not have ever had this type of stressor to face. So, and I'll very briefly talk about the tools that I teach, and then certainly people can ask additional questions. I will say when I do a coping skills approach, it does presume a certain level or degree of motivation or willingness to participate, because it is an action-oriented treatment. So if anyone is too severely depressed, has untreated ADHD where they really can't focus or put action plans in place, those are some considerations for this type of treatment. But I do a science lesson about everything Dr. Ting explained, except in a developmentally appropriate way with the kids, so they better understand their bodies. We do a lot of relaxation training. I frame it more as a way of relaxing muscle tightness and tension and calming the nervous system down, not with the implication that people are just stressed and that's why they have pain. We do a lot of active distraction. We talk about the bed is only for sleeping, not for 24/7 lounging, which is a pandemic thing that has gotten out of control, as you probably can all imagine. We work on pacing activities. So there certainly is the tendency, what I call the ping pong approach, where there's a good day and people take advantage of it and do as much activity and catch up homework as they can and then crash the next day. So we talked about how to do pacing and energy conservation. A lot of the traditional work on anxiety and depression, pain-related worries and beliefs, and then a lot of the healthy lifestyle things that you as physicians suggest. But guess what? It's overwhelming when they've been told to drink 80 ounces of water each day or dramatically change their sleep schedule. So those are all the behaviors that I work on as it relates to chronic pain. And I'll keep it simple like that. We certainly work with family dynamics, parenting strategies as well. Some of those are more unique and dependent on the age level or the developmental level of the child or teenager.
Thank you. Maybe kind of pull in, Jennifer kind of brought up the parent perspective, maybe ask either Barb or Shannon. Shannon, I'll have you wear your parent hat for a minute. We'll come back to your PT hat in a few minutes. But if Barb or Shannon, you know, sort of just from a parent perspective, some of the things that they have found helpful or some of their struggles. And I think we can definitely learn, because even though we are pediatricians, right, obviously in these situations, we are often treating the whole family too.
Yeah, this is Barb. I can share. Yeah, I think with my son, I don't know if all kids do this, but he got to the point, because he was always in so much pain, that he associated that with, I have to go to another doctor. You know, they see so many different doctors when they have severe polyarticular JIA that he just didn't want to have to go to the doctor again or have another procedure. So he wouldn't tell us. He got to that point. And I remember he was sled riding on a Monday night, Tuesday morning, got up to go to school, and he just said, can you call Dr. Passo at Children's, was his doctor at the time. Can you call him and see if he can get me an x-ray after school today? And I'm like, yeah, what's the matter? And he said, my ankle's bothering me. So when I called them, he's like, yeah, if Ryan says he's in pain, he's really in pain. So we better get it done. So he went to school and everything. And after school, got the x-ray. The next morning they called me and they said, where's Ryan? I'm like, at school. And they said his tibia actually collapsed and shattered. Like, you need to get him here. Like, he needs surgery. But he didn't tell us. Like, that would happen a lot. Like, he would have fractures in both tibias or whatever, but he just wouldn't tell us because he didn't want to have to go to the doctor again. So I think a lot, maybe kids do it different. Like, some are complaining a lot and, where their pain's not as great. And then others, the paint's really great and they're not complaining at all. So it's hard, I think, to have that happy medium where they're doing the right thing and just, it's one or the other. So I think it's probably very difficult for physicians to know what's the right thing to do.
Shannon, anything else you want to add? It's okay if you don't, but I want to.
Just from a parent perspective, I could see, Barb, what you were saying, that, sometimes they'll hide it because then it means that you either pay more attention to it or you, as a parent, you're like, well, now I'm going to get a lecture because I didn't drink enough water, or something like that. So I think it's really finding that balance of, of trying to figure out like where do we push that and where do we sort of gain some confidence with them of saying, I'm here for you. If you don't tell me anything, I can't help you. If you tell me things, then we can talk about it. I can send you to someone else, or, so it's really sort of, and it's the same way with patients of, sort of building that trust of, my job is to help you. Really, I'm here to serve you. And if you let me do that, then I think we'll have a good chance of helping you out. So
Shannon, Shannon and Barb, don't you think also too, it's like they have so little control over this process that it's helpful sometimes for clinicians like Ann and Jennifer and Tracy and me to say, I've always feel better when I say like, hey, these are the things we can approach. These are things, now you pick which one you want to work on, and not a laundry list. It's just like they have so little control over this disease process that I just trying to give them some control always felt better to me.
Oh, definitely. I think that helps a lot. My son even said that. I know when he went to a psychologist when we finally pulled them in, and he said he just got tired. Like everybody would say, how are you? How are you doing? How are you feeling? He's like, I just got tired of that. So I was always fine. And so what they did is they devised a plan that he would just have like a code word. If he was really in a lot of pain, he would just tell me the code word. And so nobody else had to know. And then I could call the doctor and we could try to figure something out. But I think they need some control over it for sure.
Yeah, and Rob sent me a message saying that sometimes I think they just want to vent, right? And I think we just need to be able to listen to them. Somebody was going to say something. Go ahead.
This is Shannon. I was going to say, right again, in line with Barb, as the therapist, though, I will go in and I'll say, not only am I here to help you, but like, what is your primary concern today? But even before I say that, I say, hey, how are you? And I go, and I don't mean like medically, I mean, like, what's going on in your life? So again, just sort of building that trusting relationship of like, hey, I really care about you and what you're doing and your likes and your dislikes. I think, Ann, you probably do the same type of approach. And I feel like that approach for me has evolved over time. So maybe some more experience that I've had as a new therapist, I maybe wasn't saying that. But now I really am just trying to, it gives me an idea too. I'm trying to get an idea of like, what are their interests, like, well, they may tell me, well, I really like soccer, but I haven't been able to play well, or haven't been able to play much lately. I said, oh yeah, what else do you like? And then I'll go back to the soccer and say, what's been going on with soccer? Like, why haven't you been able to play? Is it your coach? Or, not really making it about their physical issues or their physical impairments, but like really like, how is it affecting them emotionally? And then I feel like that helps me almost get like a back door into like, well, let's talk about that a little bit more. And then we go forward on that. So just again, that building that trusting relationship. And Barb, you're bringing that up is so true that like a lot of times you say, hey, how are you doing? Fine. They don't want to really tell you much, but if you ask about their interest and what's going on in their life, maybe it's a girlfriend or, a play at school, then they tend to open up a little bit more.
I'm going to open this up, and Shannon, you may have a comment on this. Some other people, we had a question. Oh, and Tracy just responded to, but any experience with other alternative therapies like massage or acupuncture?
When I talk to patients, I really feel like I do more of the whole body approach. I give a lot of times very little exercises. I do a lot of education, and it goes along with Dr. Bowling and just talking about, you know, strategies to help. Like I'm going to say, hey, our recommendation is 70 to 80 ounces of water, but then I'm going to talk about strategies to do that. But I'm not opposed to trying other things. Like if they find that massage is what helps them and helps them relax from a mental and a physical standpoint, then let's do massage. If they've had if they've tried acupuncture in the past and it's helped, let's do it. I try to educate them on what they may expect or what they could expect from that. They talk about chiropractic care. If I'm trying to protect their joint, I'm going to tell them exactly what could be the risk of that. I always say that chiropractors and physical therapists have a love-hate relationship. Chiropractors can give you that great quick fix, but the physical therapist is going to say, but why is that happening? Why do you need to get realigned every time? And so there can be some great complements between those kinds of interventions. And I feel as a therapist in this day and age where we have lots of options, we need to really keep our minds open to that, but then be able to educate if we know on some of the maybe contraindications, or just to allow them to know what to expect with those.
One thing I will talk with families about with other alternative therapies is I have had a couple of families that aggressively pursue a variety of therapies to the detriment and the exhaustion of the child and their ability to have like a normal after school life, because every single day of the week is. So I always joke sometimes that you could be therapy to death and they can all be extremely helpful treatments, but if there's too many of them at the expense of being able to do their PT stretches or a little bit of downtime. It seems like, and I'm sure it's kind of woven through all the different areas of this, is trying to strike the balance. And I actually really emphasize, and like, your body has to have a very balanced lifestyle to be able to cope with a chronic medical problem, including pain, which is the regular sleep schedule. But I really try to keep coming back to like, to that part, including when it comes to therapies. And I don't profess to be able to recommend one over the other when it's alternative, and I take the same approach as everybody else. Like, I think personal experience is very much different from one person to the next. But I have seen a few families who are doing the right things, but way too much of it. Like, just why don't you just have downtime after school and go home and do your homework and relax and just,
It's almost like having too much furniture, too much good furniture in a room. And it's like, they're all nice pieces, but after a while you can't move if you have too much of it in there.
Absolutely. And so it's always a fine a balance between values and kind of respecting, but then also offering observations. And that's where, again, I feel like I have the luxury of having longer. I mean, I get to spend 45 or 50 minutes with a patient during a session. I get to know more about family values. And so, again, sometimes this stuff comes out more with me than it might when you only have 15 minutes to ask your most pressing questions with the medical providers. So, right, I get a little bit of a luxury, like Shannon, of getting more time to spend with them for sure.
Yeah. Chelsea, I'm going to ask you if you wouldn't mind just commenting. I kind of mentioned, I think one of the things that I sort of see these kids and families sort of through a journey, right? So first, it's initially trying to find out the why, right? So what's they want a diagnosis, right? They're fixated, especially my kids with chronic abdominal pain, right? Well, there's got to be something, physically with the stomach. And then, we find out that there's probably not actually something that we can diagnose, and they get diagnosed with a chronic pain syndrome. And then it's, well, I want to be pain-free, right? I don't want to be pain-free. And then eventually sort of coming to that realization that, you have to switch your thinking from sort of, I'm never going to be pain-free, and how you make the most of that and how you live your life. And so if you wouldn't mind maybe just kind of sharing sort of what that was like for you, and you may still be going through that, I don't know, but just kind of where you're at and how that's affected you.
Yeah. So, I mean, like, it is difficult to come to that realization. I feel like it's one of those things that you just kind of deal with, I guess. But it's it's definitely difficult when you go from the mindset of I just want to be pain free to, you know, to going to, you know, you're always just going to be in pain and just having to deal with it. But you know, I would say that I kind of have always kind of had the mindset of that it is always something that I'm going to deal with, that that I can't really change it. So it just is one of those things that I haven't really had a cognizant I haven't like been aware of it. But it's just always something that I just was that I just, you know, it just was always something that just was always there. And so I just haven't known any differently. So I think that that kind of made it easier for me. Just because I was diagnosed at, you know, just such a young age and everything, that, you know, that the pain was all I've ever known. So it isn't really something that I've had to come to like a realization for or anything.
Thank you. You know, I think I'm going to ask, I think, Dr. Lynch, this question, because I think, you know, one of the things that we see in primary care, we see our kids, we know that they need some mental health counseling, our kids with chronic pain, you know, and obviously, you know, majority of us are focused here in Cincinnati. We know we have other people on the webinar that are not in Cincinnati. So I'm not, you know, sure what resources you have, and can only see so many patients, you know, for us. So when is that, I guess what I'm asking is, when, for a child with chronic pain, when can sort of a, you know, a counselor in our office, or, you know, a counselor through Cincinnati Children's or Nationwide Children's that's not specialized in pain management, when can we refer them to you and to them? And then when does somebody that has more expertise like you, when do we need to consider that?
I usually kind of think about, first of all, is pain the only stressor they're going through? Or are there multiple other stressors in their life, where if pain is one of 5 other things the family is dealing with, then basically general stress management with a counselor in a pediatrician's office or a counselor in the community would be very relevant, because a health-oriented focus would only be tackling one of 4 other stressors, like parent divorce or changing schools or moving. And I would actually be doing a disservice to them, because I would be addressing only one of the stressors in their life. That might be a time that I would more refer to a community provider. Or if I just see this patient as, yes, having pain, but it's also just, you know, ever since you've ever known them, they've been a chronic worrier and perfectionist. Clearly, that's going to be a personality trait that's likely to flare or cause challenges in their life over their childhood and adolescence. Having a general mental health provider to be able to support around that. Sometimes I kind of co-treat. So there is the general mental health provider, and then pain becomes its own disabling problem, and the general mental health provider is doing excellent work around social anxiety or life stress, but really needs the partner to focus more on the health-related adherence and coping skills. And then I do a supplemental 4 to 6 visits around those pain-focused coping skills, and being able to hand back off to the community provider. That works really well. I think the other thing is, as I mentioned, if the patient appears to be so severely depressed that they can't even maybe do a type of coping skills treatment, really, that's when I send them to psychiatry or back for medication management and a general therapist, just to stabilize mood. Again, if there's serious safety behaviors, where that clearly would be the first focus of treatment, again, community mental health would be able to get them in far faster than more specialized services. Where I would send them to a health or pain psychologist, if pain is the primary stressor in their life, all the emotional reactions of anxiety and worry and sadness and irritability stem solely from their pain and pain condition, that may be like otherwise kind of unfortunately ignored by a community mental health provider who doesn't know much about chronic pain, that's when I would very specifically send them to someone who is much more familiar with chronic medical conditions or chronic pain conditions. And I don't know, Chris, if you have any other specific like symptoms or ideas you have like questions about, but that's generally how I kind of think about it.
No, I don't think so. Anybody else feel free. I want to sort of ask, this is kind of related to that. I'm going to ask one more question, and then I know we have some resource slides. I want to be sure we get to those, and then we can wrap up. We're getting near the top of the hour, but I know, Chris, I don't know if you, I know I get this a couple of times often, and maybe some of the other PCPs on the call. I get a family I'm taking care of, a child I'm taking care of with chronic pain, and I get that call from the parent. You know, it's just they're struggling to go to school, and they want me to write that letter saying they should just homeschool for the rest of the year. And I always struggle with that. So I'm going to open it up to our experts. What's that line between pushing kids to function and get to school versus when is it you need to let them sort of heal and back off? And I really struggle with that. So I will open that up to our panel.
I will tell you that this is coming up right now because there are several people who are at critical absence levels and far behind in school. And this is a discussion I've had with several families, as I'm sure you guys have too. I try not to take an all or nothing approach. If with the option of virtual or online programs, there needs to be that just for like credit recovery or trying to catch up, I try to make it as flexible as possible. Like, okay, we will do that for the next month. I don't want them signed out of school till the end of the school year, because then it will be 6 months until they are physically back in school again in August, which leads to just a lot of social anxiety and school avoidance that hasn't been addressed. So I am very much a proponent of partial days, partial online catch up, anything that sort of keeps them at least directly, I would say like get your feet in the door of the school at least a little bit. If they're so severely behind, they have to have some sort of modifications. That's what I advocate for. I know that takes a little bit more finagling, and that's often what I do because I know, again, not everyone has the time to kind of manage those types of plans. But that's kind of, I really don't like the all or nothing approach. I really like, let's see if we can modify this to keep you in touch with the school.
That's a great idea, Anne. I'm going to definitely use that one more. That's great advice. You know, the other thing too is like, I think you have to use I struggle the same way, Chris. And I think one of the things that recently there's been a lot of acknowledgement of how important it has been to get kids back in school with the pandemic. And so sometimes I use a little bit of that logic saying, you know, like just like it is with the pandemic, it's like we got to try to do the best we can to keep kids in school. We really got to work on this because it's important. We know from the pandemic how important it's been, but just to try to get kids and families to understand that too. I struggle with this one so much, but I love Anne's approach of just trying to not do it all or none.
And we had this point where, like yesterday with a patient who has a lot of diagnostic uncertainty, I'm like, okay, he's a high school student, and we even got like one class a day in person, just so you don't lose the social comfort of being there, seeing friends, right? You have to have a flexible school who's willing to do it, and you've got to have the time to try to negotiate that, or the parent who's a good liaison. All those factors aren't always in place. And so there are some situations where, you know, and anymore, I don't really advocate. The parents will just pull them out and put it in school, put them in online or K-12 school anyway. If that happens, the next thing I do is I go back to like, we have to structure your day. If you're not in school, you're still waking up at nearly the same time, you're going through your morning routine, those sorts of things. Otherwise, like you saw in the pandemic, sleep schedules go to, you know, like people are in their PJs all day, that sort of thing. So if that's the next thing I do is if they've gone to an online schooling, I try to preserve as much of their daily functioning and schedule as possible, just so we don't have multiple problems besides attending school to deal with.
From a specialty hat, I always try to figure out what the other people that are involved in the care are saying about school and then be supportive. I guess that's the approach about any of the patients that I see that, you know, if they have rip roaring lupus or pJIA, then I know what my role is. But otherwise, I'm always trying to figure out how can I be most helpful to the person that sent them to me. So if you have clear things like don't agree to online school or something like that, if you make that clear to me, I'm going to be sure that I support whatever, because you can know the whole family dynamics a lot more than us and things like that. So be sure from a primary care perspective to keep us up to date with what would be helpful to you.
Great. Well, we have about 5 more minutes, and I want to make sure we get through these last set of slides because it's got some resources. And again, we will make sure that you get these slides. But Tracy and Jennifer, I guess if you just want to kind of walk us through these last final review and resource slides.
Yeah, I just had a couple of pearls. I recognize, again, as Anna was saying, we are blessed with time that primary care docs are not, and clinicians. And so if you, again, can just highlight, we wanted to highlight a few key areas. So we know the definition of chronic pain, that this sort of pan-positive review systems can already lead you to the sense of what might be coming, fatigue. And I think folks have stressed strongly about sleep hygiene. I think if there's one question that you can ask to kind of capture the sense of how sleep is going, my favorite question is, do you feel rested on awakening? It could be 8 in the morning, 6 in the morning, it could be 2 in the afternoon, whatever their usual wake time, are they rested? And that right there can give you a good sense of the quality of sleep. And most of the time it is not. And so again, focusing on sleep is critical. I do stress again with that negative stigmata, it's not about anxiety, depression, and that's the source of all the pain. Is really that kind of intertwined component of chicken or the egg, and that again, our mental and physical well-being are so intertwined that we can't separate the two. And then again, just on exam, we as specialists, if you have a patient with pJIA or lupus and also has chronic pain, that's on us to make sure that the inflammation is well controlled. And even for us, it's difficult. We have several patients we can think of that have overlapping symptoms, and that's where some of our tools like ultrasound or imaging have been helpful as well. Next slide, Lori. So this is an old graphic as well, but a nice one, I think, just to show again that sort of pattern of where everything leads to pain, but so many things and factors are involved. And on the right side, a lot of it is sort of the psychosocial piece, and on the left side, a lot of the physical. And some of the key components ask about activity, ask about sleep, and I think diet, honestly, is a good one as well that maybe we should sneak in there. Next slide. And then just a few management pearls. Again, I think folks have stressed already, sleep, and more sleep without electronics, ideally. Movement, Shannon has some wonderful tips. If they need a coach, I agree with Anne. Like, I feel like I'm more the life coach. I spend more time just listening and really guiding patients to understand what are your triggers and what did you do to make it better. And they're really leading the visit. I'm just sort of guiding them there and reinforcing what's correct and maybe what they could work on. But if you have a patient that's particularly hypermobile or just needs that kind of training coach, I think about PT and OT. I think also what's been addressed is, and I learned this in my years of practice, that I forgot to manage expectations. So kids would get this diagnosis, we talk a whole lot about it, and we give them things to do. And of course, at that point, they're already unhappy and like, I can't do all this stuff that they're asking me to do. And I forget to mention that, this is not a quick fix, there is no quick fix. It's not going to turn around rapidly, but patients can get better. So it's really setting the tone, acknowledging the diagnosis, recognizing that there's no magical pill here. There are no FDA approved medications for juvenile fibromyalgia, at least, or chronic pain in children. But this list, the second bullet, are just some options that have been utilized and I find can be effective depending on the main components of the symptoms, right? If patients are struggling with sleep, we focus on sleep. If they're struggling with anxiety or depression, that can be helpful. If it's more nerve pain. So again, thankfully there's overlapping success with these medicines for multiple symptoms as well. And then again, just setting the tone, it will take time and you may flare, but we'll be there for you. I think from a primary care perspective, I can imagine needing to check in multiple times and doing exactly as Chris was saying, like kind of focusing on 1 or 2 things for each visit. And then next slide, this is a little bit of a plug. So I think in the article that you received, there is this new questionnaire. We looked at it several years ago at trying to modify it from adults to kids. The form in the paper is actually the adult form. This is the modified form really for pediatrics, where in the bottom C table, there's a lot of different symptoms that are better specified for children. So you can use that as a quick screener. Does somebody have chronic pain? next, and then I think you could just hit the next two buttons if you want, Lori. So we do have a couple of clinical trials if folks are in the area, or even and throughout Ohio, we have some other centers where we're looking at ways that we can help kids with chronic pain, as well as studying what might be going on in terms of functional MRI studies and a whole host of other things. So this is here for your reference, and if you have any questions, please don't hesitate to reach out.
At the end, I have a list of some various tools to highlight because I know not everyone has access to specialized health psychology, or the wait times are quite long. The two that I would particularly highlight, particularly for, I would say, adolescent or young adolescent patients. The first is a workbook that was developed specifically for teenagers. So it's written for them, not for treatment providers. It teaches a whole variety of coping skills along the cognitive behavioral therapy approach. It's great. I use some of the different supplements in my training in treatment as well in session. But a self-motivated family could easily read and work through this in piecemeal fashion, or just doing selective things. It's only about $20 on Amazon, so it's not crazy unaffordable. And then on the next slide, there is a free app, web map mobile app. It was designed through Seattle Children's Hospital and their pain program. It is a self-guided, self-paced cognitive behavioral therapy program. Again, obviously this is for a more motivated patient or family, but this is a free resource, and they can, again, I've had patients do this while they're waiting to get in to see a mental health provider or a specialized psychologist. The other ones are just various resources for relaxation training, some apps for young kids, some apps for older kids, whether that's to help fall asleep at night or just for calming purposes. There's so many things out there, so I don't want to say these are the only ones we endorse. It's just a few I put on there that could be helpful.
Next slide, Lori. We can just kind of go through, keep going. Yes, we're going to actually email these out. I have some note on physical therapy, and unfortunately we're running about on time. I want to keep going, Lori. Again, we will make sure everyone gets these slides. Barb, I just want to sort of a closing comment, do kind of a comment on resources through the Arthritis Foundation.
Yeah, we have lots of things for families. We have fall family camp, we have juvenile arthritis conference, juvenile arthritis days. And what those do is they allow families to meet other families that are going through the same thing, but at the same time, they all have education. So they help get the tools that they need to learn to manage their disease.
Great.
So feel free to reach out to us anytime, and the website's there and my number's at the bottom.
And thank you for joining us.
You're
Next
welcome.
slide, last slide, I think, actually. Just sort of a wrap up. First off, I want to thank those of you that attended, and I really want to thank our panel for taking some time. This was invaluable. I think we're seeing more and more of this in our practices, and just very lucky to have the collection of knowledge and experiences that we were able to share today. We mentioned earlier, there is the online asynchronous journal club where you can get 20 points of MOC2 credit. You can go to that link for more information, and Lori in a follow-up email will also send that link. And then of course, if this is the first webinar that you joined us, please feel free to go back and look at our other webinars. They're there. And lots of a little bit more didactic oriented, but all really phenomenal. The first one was just sort of an overview of pJIA. The second one was really a show and tell that Dr. Huggins and Shannon did, with Shannon demonstrating some physical exam techniques. And then the third one was really looking at treatment options for pJIA. Next slide, Lori. I think it's our last goodbye slide. So again, thank you to our panel. Couldn't have done this without you. Special thank you to Lori and Jennifer. This has been an amazing project, and I've enjoyed working with both of you. And hope you all have a good day, and look forward to working with you guys and seeing you with other chapter activities. So have a great afternoon, everybody.
Bye, everybody.
Bye, thank you.